Hi, I'm Dr. Esther Freeman, and I'm pleased to share our cost-effectiveness analysis of 4 chemotherapy regimens for treatment of AIDS-associated Kaposi sarcoma in Kenya. And this is on behalf of East Africa IDEA. HIV-associated Kaposi sarcoma continues to be highly incident in the sub-Saharan African setting. This is even in the modern treat-all antiretroviral therapy era. Most patients diagnosed with advanced stage KS continue to require chemotherapy in addition to antiretroviral therapy, which alone is often insufficient for these patients. We know from clinical trials that agents like paclitaxel and pegylated liposomal doxorubicin, which is an example of a liposomal anthracycline, are indeed clinically most efficacious. A recent trial by Crown et al. In the Lancet last year in sub-Saharan Africa did a head-to-head comparison between paclitaxel and the more commonly used regimen of bleomycin vincristine and found that paclitaxel was more efficacious. Currently, in Kenya and in many other settings in sub-Saharan Africa, bleomycin and vincristine are the most commonly used combination, even though we know this is less efficacious, and this is due to high cost. Therefore, we wanted to evaluate the cost effectiveness of different chemotherapy regimens in the sub-Saharan African setting for Kaposi sarcoma. We used the CPAC International model, which is a validated microsimulation model, which is usually used for HIV disease and some comorbid conditions. We added on a Kaposi sarcoma module in order to do the cost effectiveness analysis for this project. We then projected cost effectiveness of paclitaxel and compared it to other regimens, for example, pegylated liposomal doxorubicin, and compared also to regimens such as bleomycin vincristine and etoposide, both of which are currently used in Kenya. In terms of the model inputs, these were derived from our prior epidemiologic work through East Africa IDEA out of Kenya, and also from the Crown trial that I mentioned in the Lancet, which is where the progression-free survival was calculated from. So let me orient you a little bit to our results. Going down the left side here, we have the different types of chemotherapy regimens: etoposide, bleomycin vincristine, paclitaxel, and liposomal doxorubicin. We have the projected discounted life years in terms of expectancy and of cost. And the most important column on this page is the ICER column, which is the incremental cost effectiveness ratio. The ICER is the difference in cost divided by the difference in life expectancy between a given strategy and the next least costly strategy. So how do we decide what's cost effective? So there's different ways to determine a cost effectiveness threshold. Here, we determined that the cost effectiveness threshold would be half of the per capita GDP of Kenya, and this is a relatively standard way to calculate it. So using this calculation, anything less than $860 per year of life saved would be considered cost effective. So you can see that paclitaxel with an ICER of $380 per year life saved is considered cost effective and is actually far below this cost effectiveness threshold cutoff of $860 per year life saved. In terms of pegylated liposomal doxorubicin, currently has, depending on the cost, has an ICER that would be higher than $860 per year life saved. We did a threshold analysis to try to understand at what cost would pegylated liposomal doxorubicin become cost effective, and its cost would need to be reduced from $180 per cycle to $80 per cycle. In addition, we did something called a budget impact analysis. So this is evaluating for the entire country of Kenya if Kenya were to shift from providing BV or bleomycin vincristine to paclitaxel for Kaposi sarcoma, HIV-associated Kaposi sarcoma treatment. What you'll see is that there is a significant bump in total life years saved from 41,000 life years currently with BV to 47,000 life years with paclitaxel. You'll also notice that it saves about 6,000 life years and does increase 5-year costs by about $3 million. Interestingly, what drives that increase in costs is not actually just paying for the chemotherapy. That's actually a small portion of it. 72% of the increase is actually due to HIV-related costs because patients are living longer and having better survival. So that's a good thing. So overall, we believe that this analysis shows that for adults with Kaposi sarcoma who require chemotherapy in Kenya, paclitaxel should be widely implemented as first line because it is cost effective and will also increase life expectancy compared to bleomycin vincristine. Pegylated liposomal doxorubicin would really only be cost effective if its price were substantially reduced from where it is right now at a per cycle cost. I'd like to thank all of our co-authors, especially those in East Africa IDEA.